Hello everyone. We have a 46-year-old man. He come to emergency department, intermittent severe right flank pain over the past few days. He has decreased urination over the last week. There's an episode of high urine output along with a feeling of generalized weakness. There's no family history of renal disease. On examination, BP is 145 by 86. Heart rate normal. If you look into serum chemistry, there is hypokalemia is there. Creatinine is slightly on the upper side of normal. Urine is normal. Most likely cause of this patient's symptom is. The answer is urinary outflow obstruction. Patient has a total history of nephrectomy. Now he has most likely unilateral obstructive uropathy due to renal calculi. Now, how can we support a diagnosis? Flank pain, that is due to renal capsular distension. Poor urine output, mechanical obstruction of the urine outflow. So, now intermittent severe pain, right flank pain over the past few days, he had a decreased urination of the last week. That are the classical thing that has been given in the question, which is supporting the diagnosis of obstructive uropathy. Now, intermittent episode of high volume urination can occur when the obstruction is overcome by large volume of retained urine. This is so-called post-obstruction diuresis. Episode of high urine output along with a feeling of generalized weakness is there. Excessive diuresis may lead to potassium wasting, and that dehydration that can cause weakness. And remember, in our case also, serum potassium is just 3 milliequivalent per liter. So this is the reason why patient has weakness. Now, post-obstruction diuresis may be seen in patient with bilateral functional kidney, as affected kidney will produce a large volume of urine when obstruction is relieved. Again, same feeling, episode of high urine output along with feeling of generalized weakness. However, patients with single kidney are more likely to develop acute renal failure than those with both kidney intact. Very obvious, when single kidney is there, more likely to get failed. Let's look into other option. Glomerulonephritis. Glomerulonephritis consists of hematuria, RBC cause, acute renal failure, hypertension, and edema. But in our case, urine is totally normal. There is no RBC. Or remember, abnormality we say when 3 or more than 3 RBCs per high power field, then only we say microscopic hematuria. This can be a normal finding also. Anyway, this is not a case of acute glomerulonephritis. Inherited renal disease, leading cause of inherited renal is autosomal dominant polycystic kidney disease. It comes with persistent abdominal or flank pain, hematuria which goes gross or microscopic more than 3 RBCs per high power field, as I told you in the previous slide. Okay, but there is a positive family history in 75% cases because this is autosomal dominant condition. Half of patients will have hypertension at presentation, but in our case there is no family history of renal disease and BP is almost in the normal range or slightly raised, but this is not a feature of so-called ADPKD. Interstitial nephritis most frequently occur due to drug reaction. Patients usually have fever, rash, acute kidney injury, eosinophiliuria, white blood cell cast. But in this case, there is nothing like this. Urine examination is almost normal. Renal stenosis may come with hypertension, with or without kidney injury, but in our case, BP is almost in the normal range. Doesn't cause flank pain or urine symptom, so this is ruled out. Obstructive uropathy present with flank pain, low volume voids, without occasional high volume voids, and if bilateral, renal dysfunction can be there. Thank you very much.